This is Aging Forward, a podcast from Mayo Clinic about the science behind healthy aging and longevity. Each episode, we explore new ways to take care of our long-term health, the health of our loved ones, and our community so we can all live longer and better. My name is Kristen Meinzer. I'm a writer and journalist, and I'll be filling in for Dr. Chen for the next several episodes. And this episode, we're talking about heart failure. About 80% of Americans with heart failure are older than 65. As we age, the incidences of heart failure increase as people develop risk factors like hypertension and coronary artery disease. Our guest is Dr. Omar Abu Ezzedine, a cardiologist based at Mayo Clinic in Rochester, Minnesota. Dr. Abu Ezzedine is also an associate professor of medicine at Mayo Clinic College of Medicine and Science, and today he'll talk us through what heart failure looks like in different forms and at various stages. He'll also share what life after heart failure might look like. Dr. Omar Abu Ezzedine, welcome to the show.
Thank you so much for having me.
Thank you so much for being here. So let's just start off with the basics. We're talking about heart failure today. How did you get interested in this field?
Well, I was drawn to heart failure because it combines science, technology, but more importantly, it's a very human clinical care. And these are patients that come and see us that are truly affected by debilitating symptoms of shortness of breath, fatigue, major limitations in their quality of life. I was also attracted to the detective work that comes with the field, not just labeling someone as having heart failure, but understanding why the heart is failing. You start learning to focus on specific conditions where an accurate diagnosis really can change a patient's clinical trajectory and treatment pathway. And with the right diagnosis and treatment, we can often dramatically improve how they feel and how long they live even.
All right, so let's ask a question that probably everybody thinks they know the answer to, but actually when we think about it, we don't necessarily know the answer to. What exactly is heart failure?
It doesn't necessarily mean that the heart stops working per se. It means that the heart muscle is not keeping up with the body's needs, essentially. And that can happen either because of a heart muscle being weak or not being able to pump normally, and we call that systolic heart failure, or if a heart muscle is becoming stiffer as we advance in age, for example, and it can't fill normally or relax normally. And in both those cases, patients may have similar symptoms of shortness of breath and fatigue and fluid retention, reduced ability to exercise. But really, the reasons and the actual pathology that's causing these symptoms is quite different.
You did mention aging being an aspect here. What does aging have to do with the heart failing?
So as we age, our heart and our vessels become stiffer. Over time, common comorbidities like high blood pressure or hypertension, diabetes, obesity, kidney disease, coronary artery disease, all these cardiac comorbidities or risk factors, they place this stress on a heart. And so aging itself is not destiny, but aging gives these risk factors, if you want, these comorbidities, more time to impact the heart and cause it to become stiff or weak over time.
Got it. I don't know the difference between heart failure, heart disease, and a heart attack. And I feel like I sometimes hear these terms being kind of used interchangeably, but they're not the same thing, are they?
No, and that's a great point you bring up. Heart disease is sort of an umbrella term we use for problems with the heart valves, the heart arteries, the heart rhythm, the heart muscle, really various parts of the heart. A heart attack specifically refers to when you have a sudden blockage in the blood supply to the heart muscle, and that's typically what we call myocardial infarction. Heart failure is more of a clinical syndrome where a heart can't pump strong enough or can't relax easy enough to keep up with the body's needs. Now, a heart attack can ultimately, with time, cause heart failure, but many patients can develop heart failure without having had a heart attack or for many other reasons, which we can delve into as well.
Okay, so three distinct things, but all related to each other, and one can lead to the next.
Exactly, yeah. And heart disease is more of an umbrella term, if you want, for all of those things.
And what conditions or risk factors may lead to heart failure?
So, the most common in North America that we think about include high blood pressure, coronary artery disease, or coronary artery atherosclerosis, the plaque formation in the arteries that supply the heart muscle, a prior history of heart attacks. Diabetes and obesity is increasingly becoming very problematic as well. Atrial fibrillation is a rhythm issue in the upper chamber of the heart. Valve disease that could be degenerative or age-related. Kidney disease, things like sleep apnea, which also goes sometimes with obesity and high BMIs. All these things can ultimately play a role as a risk factor. Increasingly, in younger patients, we're seeing alcoholism or a drug toxicity, illicit drug use as well. And on the other end, sometimes other medical conditions like certain cancers that require radiation or chemotherapy in and of itself is a toxin or a risk factor for developing heart failure.
Something you alluded to earlier is that there are multiple kinds of heart failure. So let's walk through those, starting with left-sided heart failure. So there's a couple of kinds of left-sided heart failure, right?
Exactly right. So the heart has two lower chambers, the left and the right side of the heart. The right side of the heart pumps blood to the lungs to become oxygenated, and then oxygenated blood comes back to the left side of the heart, and then that acts as the main pump of the body, pumping blood out to the rest of the body, the brains, and all the organs. Left-sided heart failure can either be a problem of weak heart muscle, where you've either developed a heart attack or gotten exposed to chemotherapy or illicit drugs, for example, so whereby heart muscle can't pump enough blood for the body's regular use. So that's typically called systolic heart failure. So with each beat, the heart can't pump out enough blood. So what we call the ejection fraction, so that pumping fraction is low. Another kind of left-sided heart failure is diastolic heart failure, and that typically has preserved ejection. You could still have heart failure symptoms, which we mentioned, but the heart muscle is stiff. So it fills under higher pressures, and those higher pressures ultimately reflect back to the lungs and cause breathlessness or shortness of breath with activity, and that could also cause fluid retention in the lungs. So typically, left-sided heart failure presents with congestion. Now, on the other side, right-sided heart failure, those patients typically end up with congestion on the right side of the heart. So rather than congestion in the lungs, it's more congestion in the liver, kidneys, and legs, and the organs that feed blood back to the heart.
Got it. You're using the word congestion a lot. Does that mean that all of the things we're discussing are technically congestive heart failure, or is congestive heart failure something else entirely?
No, that's exactly. So congestive heart failure is simply an older term that emphasizes fluid buildup or fluid retention. It's just an umbrella term to describe what happens when heart failure leads to fluid building up either in the lungs, in left-sided heart failure, or in the legs, abdomen, and other tissues in right-sided heart failure.
Got it. So if I'm understanding correctly, congestive heart failure, fluids are building up, and in some cases, certain parts of the heart are too stiff or they are too weak to really do their jobs well.
Exactly right.
All right. So which of these conditions we're discussing are more common in older populations?
So in older populations, typically heart failure with preserved ejection fraction is more common. As patients get older with degenerative valve disease, heart failure that relates to long-standing high blood pressure or hypertension, other comorbidities like long-standing diabetes, these things are more common as we advance in age. And secondary to those, you can have a more stiff heart muscle in the setting of either a hereditary mutation or simply advancing age, you can develop this infiltration of your heart muscle with proteins that cause the heart muscle to become stiff. So in this case, you have a stiff heart muscle, so you don't technically have a weak, it's more heart failure with preserved ejection fraction.
So diastolic heart failure then.
Exactly right. So one major lesson that I've come to appreciate more in my career is that HFpEF, or heart failure with preserved EF, is truly not one single disease. It's very heterogeneous. In fact, HFpEF is more of a syndrome with many possible drivers rather than a condition per se. Some patients have HFpEF, or heart failure with preserved EF, because of obesity, high blood pressure, diabetes, chronic kidney disease. It really is a basket, if you want, of many different etiologies that cause the stiff heart muscle. Other patients were, like I mentioned, increasingly recognized infiltrative diseases, where you have certain proteins that infiltrate the heart muscle and mimic, if you want, this syndrome of heart failure with preserved EF. So the key is not to stopping at the label of HFpEF, but to ask what is actually driving this heart failure in this particular patient. And this is where personalized treatment truly begins. We're really starting to appreciate different, what we call phenogroups, different phenotypes of patients within this big umbrella that historically we've called diastolic heart failure, or heart failure with preserved ejection fraction.
I love the individualization of care and how we're starting to evolve in that direction. Not that long ago in the past, all of the study subjects were like, okay, 18 to 25-year-old white men, how do they respond to this? How does this occur in their body? And it sounds like what you're doing is looking at something that's much more inclusive and also looking at a broader array of what could be considered symptoms and so on than were recognized in the past.
Exactly right. And, I think with novel technologies, we can delve into a patient's own genetic code, and we can decipher certain risk profiles that predispose them to heart failure, what this patient's been exposed to in their history, either environmentally or their genetic code.
That's fantastic. All right, let's talk about symptoms and testing. So, what are the symptoms of heart failure? Do they differ depending on the type of heart failure or the type of person who is experiencing heart failure, let's say a man versus a woman?
Yeah, excellent question. Now, most common symptoms of heart failure are shortness of breath, fatigue, fluid retention, which can manifest as swelling in the legs and the abdomen, in the lungs, causing difficulty laying flat, for example, or waking up in the middle of the night, gasping for air. Rapid weight gain, we say normally 3 pounds or more in 24 hours or 5 pounds or more in a week, is likely to be fluid retention rather than caloric weight gain. Reduced exercise capacity, and sometimes palpitations and lightheadedness and even passing out can be symptoms of heart failure. Now, sometimes we're increasingly now appreciating that there indeed may be sex differences in how patients have symptoms of certain cardiac conditions. And this has been very well documented in coronary disease, for example, where chest pain or angina has different manifestations in men and women, and it's sometimes under-recognized in women because they just manifest it differently. And so while in heart failure, we don't see that distinction as much, sometimes chest pain is described very differently between the sexes.
And when should somebody who's experiencing these symptoms actually pursue medical care?
Urgent care or emergent care really should be sought if you're having severe shortness of breath at rest, chest pain at rest or with exertion, any fainting or palpitations that are unexplained, or rapid weight gain that patients develop that is associated with any of these symptoms that I have mentioned. I also mentioned to my patients if you have known heart failure and you can't lay flat or you're waking up gasping for air, that's a sign that you should seek medical attention emergently.
And when heart failure is happening, are there specific stages that the body goes through that we should know about?
Yeah. So typically the stages that we talk about in heart failure have been designated by the American Heart Association and the American College of Cardiology, stage A to stage D. So stage A heart failure is when you're at risk of developing heart failure. So you have one of these comorbidities we discussed, either diabetes or obesity or coronary artery disease, but there's no structural change to the heart muscle that is identified yet. And there's no symptoms. So that's at risk of developing heart failure. We call that stage A. Now, once someone who is at risk, who has these comorbidities or risk factors, develops a structural change in the heart muscle, then that becomes considered stage B as long as they don't have symptoms. So in the absence of symptoms, a heart muscle that has been affected in one way or another by a heart attack, by diabetes, by obesity, become more stiff, more weak. In the absence of symptoms, that's stage B. As soon as you develop symptoms of heart failure with the structural changes that have occurred in stage B, then that becomes stage C heart failure. And that's the bulk of our patients. The bulk of our patients are on medications to try to prolong their life and reverse some of those changes that happen to the heart structure, if you want. And ultimately, when despite medications and devices and interventions on the valves, for example, patients continue to have debilitating symptoms and typically are rehospitalized over and over again for congestive heart failure, or if they cannot tolerate their medications anymore and their blood pressure is very low, that would suggest that's stage D heart failure. And typically that category of patients, it's important to identify that stage D early enough because the only saving grace for these patients ultimately will be advanced heart failure therapies. So we are moving away from medicines and more towards, at that point, transplantation or ventricular assist devices. So those are the stages of heart failure. Now, some patients get stages and classes of heart failure confused.
So those are the stages, but then what are the different classes?
When we talk about classes of heart failure, this is a categorization of symptoms. So NYHA, New York Heart Association Class 1 is when patients have no symptoms. Class 2 is when they have symptoms with mild activity. Class 3 is when they have symptoms with moderate activity. And lastly, NYHA Class 4 is when they actually have symptoms at rest. And so staging is more of a staging of heart failure, at risk of heart failure to advanced heart failure, A, B, C, D, and that's a one-way street. You can never go back. And then NYHA class or class of heart failure reflects more the symptoms.
Got it. And how does a provider test for the stages and classes of heart failure in a patient?
The most important thing is the history that you obtain from the patient and the physical exam. And it's from there that you really get 80% of the story. Even the etiology of heart failure, sometimes just from the history and physical, you can decipher based on a patient's exposures, their family history, their risk profiles, their comorbidities, if they're diabetic or if they've had a history of coronary disease, for example. But after the history and physical, then we delve more into the diagnostics, including blood testing, blood work that looks at certain peptides that our heart muscle secretes when it's congested or weak, for example, kidney function testing, etc. The backbone, if you want, of heart failure practice is echocardiography or ultrasonography of the heart muscle. And that tells us really more about the heart muscle. Is it weak? Is it stiff? So is it ejection fraction preserved or reduced ejection fraction? How the valves are functioning. Is there a valve problem? Is there a problem in the envelope or the pericardium of the heart? Are the heart walls thick? So you can really gather a lot of data from the ultrasound of the heart or the echocardiogram. Advanced imaging now is including nuclear imaging and cardiac MRI, gives us a much higher resolution, if you want, of the heart muscle, where we're actually imaging, for example, with cardiac MRI, the muscle tissue, if there's scarring in the heart muscle, if there's edema or swelling or inflammation in the heart muscle. And so that gives us a different sort of window or insight into the heart. And nuclear imaging is also evolving in ways that we're now assessing the heart muscle at the cellular level, where you can see if there's heart muscle inflammation, how the heart is using energy, and how the blood flow beyond the big arteries of the heart, how the smaller arteries that provide blood to the heart muscle are functioning, where you can actually measure what we call myocardial blood flow and myocardial flow reserve. So we're moving from the more macro, if you want, to the more micro imaging of a heart muscle. And in the current era, artificial intelligence is also using all these rich data from history and physical to the cellular level findings that we have with nuclear imaging, and it's utilizing all this information to highlight sometimes patients that are at risk of developing certain conditions and recognizing them earlier. At least that's our hope with time, to get to that place.
Yeah, it seems like we've made so many leaps and bounds in the last few years in all of these diagnostics. But once a patient is diagnosed, what should they expect in the coming weeks or months or years?
Yeah. So in the first few weeks, the goals really should be to understand the cause of the heart failure, to relieve congestion. That's the most helpful thing imminently, and start evidence-based therapies that help the heart muscle, if you want, recover. Beyond that, over the course of weeks to months, we reassess the heart muscle function, the heart muscle structure over time. And sometimes, despite medical therapy, the heart muscle remains weak, and patients may be candidates for device therapies, where certain pacemakers that resynchronize the function of the heart can be considered, or defibrillators that protect the patient from sudden death because of malignant rhythms, for example. And even in the current era, structural interventions where certain valves that are leaky, despite optimization of what we call medical therapy, could be targeted with clips or valve replacements. So there are a lot of therapeutic options that occur over time. And so it's very important to establish longitudinal care with multidisciplinary teams of heart failure nurses, pharmacists, etc., to get your medications on board, but also to have your electrophysiologists and your device doctors in your back pocket, because they may need to come in, your structural disease doctors, interventional structural disease doctors, to come in and intervene on valves and whatnot.
What are signs that the condition is getting worse?
So warning signs really include progressive fatigue, muscle wasting, poor appetite, cool extremities, profound shortness of breath that's limiting you walking across the room. So these are all symptoms, if you want, that you should look out for. But also beyond that, clinical manifestations include recurrent hospitalizations, when patients are being hospitalized over and over and over again, and they're starting to develop signs of what we call end organ damage. So what originally started with a problem of a heart muscle now is a problem of the heart muscle and the kidneys, or the heart muscle and the liver with right-sided heart failure, or the heart muscle and the lungs. You can develop pulmonary hypertension. So end organ damage that starts to develop as a cause of the heart failure. So once multi-organs start to be involved, that really should raise a red flag that this patient is advancing quite expeditiously and needs urgent evaluation for advanced heart failure therapies.
With treatment, is heart failure reversible?
I don't use the word reversible anymore. I use the word remission. Structural changes happen at the molecular level that make the heart muscle inefficient or not as efficient as it was. I believe that the heart muscle never goes back to perfectly normal. Structural changes happen at the molecular level that make the heart muscle not as efficient as it was. But those novel therapies do make patients feel better. They make them live longer and they keep them out of the hospital more. So a profound improvement of quality of life, quantity of life, and really does, in certain situations, make the heart muscle stronger again. But it's not fully reversible.
That's great to know. So let's talk more about those treatments and about prevention, but let's start with the prevention side. Is there a way to prevent or lower one's risk for heart failure?
So the best prevention is truly controlling those risk factors that we've discussed a bit today. Most importantly, treating high blood pressure, better management of a patient's diabetes, maintaining a healthy weight, exercising regularly, avoiding things that progress coronary disease, such as smoking and high fatty diets, limit excess alcohol because alcohol itself is a toxin to the heart muscle, treating things like sleep apnea. So prevention means not ignoring symptoms too. So early evaluation of symptoms such as shortness of breath, such as chest pain, or unexplained swelling or fatigue is also important. Keeping up follow-up appointments, keeping in touch with your providers, because medicine is an ongoing field that's very dynamic. It evolves from day to day. And there's, when you're hooked in with a clinic like Mayo or a system like Mayo, you're really at the forefront of research. And if there's any clinical trials or novel therapies that are being considered, that would also give you access to that. And then obviously the things where, that your general practitioner would share with you, managing your blood pressure, taking medications regularly and consistently, avoiding smoking, keeping on top of your vaccinations when appropriate.
When it comes to older patients, are there specific factors that go into your decision-making when you're creating a treatment plan?
Absolutely. Age matters, but physiologic age, I think, matters more than number. I look at frailty, kidney function, blood pressure, cognition, functional status, and other patient medical conditions. But I also want to look at the patient's goals, how they're tolerating their medications, what sort of support system do they have at home, what sort of cultural background do they come from as far as exposure to certain environmental factors or certain social networks that they may have that can help support them. And this comes back to what I started with. It's a very individualized therapies depending on each patient. So age to me is just a number. And most fascinating thing in this realm, with the advent of artificial intelligence, we now can see, based on a person's ECG, their electrocardiogram, the electricity of the heart, just by putting an electrode on their heart, we can identify that not all 85-year-olds appear to be 85-year-olds according to the computer. You can have two 85-year-olds, one 85-year-old a computer thinks is 65, and another 85-year-old a computer thinks is 90. And sometimes with medical interventions, such as drug interventions, device interventions, weight loss, rehab programs, you can see sometimes that computer age of a patient actually regresses. Patients get younger according to that. Physiologic age seems to get younger with these interventions. Beyond that, it's very important that no matter what treatment you choose or you provide to a patient, that it should align with the patient's values and quality of life, more so than quantity of life. And that's something that we increasingly recognize in palliative care medicine, where patients are living longer, but it's not so much about the length of their life as much as it is important to be about the quality of their life.
Absolutely. In some cases, keeping the heart going when the rest of the body doesn't feel like it's really alive anymore doesn't sound like it's the be-all, end-all.
Right. And sometimes no two human beings have a similar definition of what quality of life means. It really varies from between any two individuals.
Yeah. You mentioned medical device implantation and heart transplant earlier. Are these more likely to happen in your patients that are physiologically older, according to the computers?
Sometimes, but it depends. Some older patients can benefit from pacemakers and defibrillators or resynchronization therapy if they've been trialed on medications and despite that they've had progression of their disease or they haven't improved, then they may still be a candidate for that. Now, when we talk about more advanced therapies like heart transplantation or ventricular assist devices, these are generally reserved for very carefully selected patients with advanced heart failure, patient age, physiologic and frailty as well. Kidney function and other comorbidities are also considered. And so typically for transplantation, for example, 70 to 72 years old, that's our limit of age where we consider doing a heart transplant for these patients. But the patient may still qualify for other advanced therapies like ventricular assist devices. We have transplanted patients that may be a bit older than that who are physiologically younger, if you want, who don't have as many comorbidities, are not frail, and have social support and whatnot. So it really varies.
Do you have any patient success stories you can share with us? Something that's been really inspiring to you?
I think the biggest one that comes to mind is a patient now 7 or 8 years ago who came to us. I need help. I'm told that I need a heart transplant. I don't feel like I need a heart transplant. I want another opinion. And, we evaluated him here, did some extensive testing, adjusted his medications, found out that the cause of his heart muscle condition was an abnormal heart rhythm, and targeted that heart rhythm and started him on medical therapy. And over the course of the last 8 years, he's had complete myocardial recovery so that his heart function, which was very weak, we were able to give him the last 8 years without having the need for a transplant. And he's currently, in his early 70s and doing really well. And so these are stories that many of us share in the clinic. And what this story highlights, and I'm going to put a plug in for Mayo here, is our multidisciplinary care. When I saw this patient, I recall it was 4:00 on a Friday afternoon. I distinctly remember that clinic because I was trying to get the patient seen by one of my colleagues in the heart rhythm clinic, and I literally walked right over, and he was seen that afternoon. We put him in the hospital over the weekend. He got an ablation that Monday. We started him on some medications, and the multidisciplinary care that we're able to provide really made a difference in this patient's quality of life and life trajectory, in fact.
Wow. That must have felt miraculous for that patient. All right. Finally, Dr. Abu Ezzeddine, we'd like to ask all of our guests this. What does aging forward mean to you, and how do you do it in your own life?
For me, aging forward means staying curious, active, connected, purposeful. Professionally, it means continuing to care for my patients, but also to mentor younger physicians and contribute to research that changes our practice. Personally, it means making time for my family, friendships, travel, health, and joy. So healthy aging really is not just about adding years to life. It's about preserving meaning, independence, and connection as we move through life.
I think that that's a great picture of life no matter how old we are, but especially as we get older. Thank you so much, Dr. Abu Azzedine. We've so appreciated talking with you today. Thank you.
Thank you so much for your time and for having me.
That's all for this episode. Hopefully you're feeling a little more informed, inspired, and empowered. If you have a topic suggestion for a future episode, you can leave us a voicemail at 507-538-6272. We might even feature your voice on the show. For more Aging Forward episodes and resources, head to mayoclinic.org/agingforward. And if you found this show helpful, please subscribe and make sure to rate and review us on your podcast app. It really helps others find our show. Thanks for listening, and until next time, stay curious and stay active.